Right, thanks, Chris. Welcome, everybody. Sorry for a little bit of delay this afternoon. Great to see everybody. We'll just wait a couple of minutes while people are filing into the Zoom room here. Thanks for joining us. Great to see everyone. We had a little bit of a problem with the link today, but Maya just sent out another email with the link again. So hopefully people that were unable to join due to a faulty link will get another email. So we'll probably see a few other folks trickling in. Our apologies for that. We don't know why there was a fault with the link today, but you're all here, so thank you. Welcome back, everybody. Just waiting another minute while people are filing in. Thanks for joining us. So great, Maya, I see you sent out that another link. I just got it myself. The updated link. Yeah, so that went out to the entire group, correct?
Yeah, everyone who registered. So hopefully anybody who is experiencing technical difficulties can join with that link.
Wonderful, great. Well, let's get started. Welcome everybody. Welcome back for those of you who are coming back. Great to see you. We'll get going, but we'll probably see some other folks trickling in as we move along here this afternoon. We've got a very exciting show for you today on recovery coaches. But just a little bit of background to begin with. We are the Recovery Science Series webinars. We are hosted by the Recovery Research Institute. I'm the founder and director, Dr. John Kelly. This is a SAMHSA-sponsored initiative run through the American Academy of Addiction Psychiatry and the Opioid Response Network. Next slide. The suspense is killing me. I'm dying over here with the suspense. What's on the next? I have no idea what's on the next one. But I do. Is it stuck, Maya?
Sorry, it's sharing on my end. Let me try to do that.
Yeah, just kind of unshare and then reshare again.
Is that all set? Are people seeing this?
Yeah.
Okay.
Great. So we're just gonna share a brief video which gives a little explanation of background about the Opioid Response Network, of which this series is a part. So take it away, Maya.
Cities across the nation are mobilizing to address opioid and stimulant use in the overdose crisis. Can't overcome this alone, but we can, together, and we are. We are the Opioid Response Network, a coalition of 40 national organizations representing more than 2 million people. We serve all 50 states and 9 territories locally through our network of nearly 1,000 professionals working across prevention, treatment, and recovery. For state agencies, organizations big and small, and individuals working to address local needs, we bring training and education to bear on your efforts. We're here to help you help others through evidence-based support, all at no cost to you. For instance, the Opioid Response Network helped the Tribal College in New Mexico join forces with local organizations to develop a culturally appropriate prevention, treatment, and recovery training series for its students. In Rhode Island, we convened correction staff from 34 states to share how our program had reduced post-incarceration overdose deaths by more than 60%. And supported them in their efforts to build similar programs in their home states. In West Virginia, we mobilized to help a clinic incorporate substance use disorder services into their practice, serving a faith-based community. We help healthcare providers in South Dakota address barriers they face providing treatment services for their patients. We're here to help those on the front lines. So, what are your needs and how can we help? Visit the Opioid Response Network.org to learn more and to submit a request for support. The Opioid Response Network, funded by the Substance Abuse and Mental Health Services Administration.
Thanks, Maya. Hopefully got all that. A little choppy on my end, but I got it all. And just to reiterate and underscore that what they said at the end there of the video is that if you go to the opioidresponsenetwork.org, you can get free consultation, technical assistance to learn how to implement various aspects of treatment or recovery support services in your own agency, in your own practice, in your own hospital, free of charge. It's all free of charge, courtesy of taxpayers through the government and SAMHSA. So let people know that this facility is available. You can put in a request for anything that you want consultation on or technical assistance with regarding treatment for substance use disorders, and particular opioid and stimulant use disorders. So just to underscore that, opioidresponsenetwork.org. And just a review here of our prior Recovery Science Series webinars. These are all on the website archived, so feel free to let people know they can view these anytime. So please avail yourself of all these really fantastic talks, of which we have another one today. Next slide. So just before we begin, we're going to have a brief polling question. So here we go. This is just to tell us a little bit about who you are, if you'd be so kind. Just fill in these and then hit the submit button, and then we'll get going. Now you have to scroll down as well once you to activate the submit button. Let's see. Very good. All right, how are we doing there, Maya?
Good, we're just around 80% of participation, so I can go ahead and end the poll and share if people are interested.
Yeah, fantastic. Great. So this just gives you all just a quick view of the results of who's here. Clinicians, scientists, prescribers, recovery advocates, healthcare decision makers, et cetera. People with lived experience, et cetera. So thank you so much for doing that. We really appreciate it. Just helps us try and reach more people that are underrepresented in our science series. Thanks for doing that. Okay, so on with the show. We're really delighted. I'm delighted. We're all delighted that we've got two fantastic experienced presenters today talking about this very important topic of recovery coaches and recovery coaches specifically in general medical settings. We have Dr. Sarah Wakeman, who is the Senior Medical Director of the Substance Use Disorder Initiative at Mass General Brigham in the Office of the Chief Medical Officer. She's also the Medical Director of the Mass General Hospital Substance Use Disorder Initiative and the Program Director of the Mass General Addiction Medicine Fellowship. She's also an Associate Professor of Medicine at Harvard Medical School. And we've also got Windia Rodriguez, who currently works as the Program Manager for the Recovery Coaching Program at the Mass General Hospital, where her years of experience is utilized in the Substance Use Disorder Initiative. Windia has been doing this for a decade or more. And comes to us as a person with lived experience and has worked as a recovery coach and trainer, and now has her own company as well private company actually of recovery coaching. So fantastic. What we'll do, we'll have Sarah and Windia present for about half hour, 45 minutes, and then we'll have some time for questions and answers, we hope, towards the end of the hour. So thanks so much, Sarah. Thanks, Windia. Over to you.
Thank you, John, so much for having us. It's great to be here, and I've learned so much from John over the years. It's exciting to talk about our recovery coaching effort, in particular in this space. I'm going to start with some of the background around how we've utilized recovery coaches in general medical settings and some of the evaluation work that we've done. I'll take some questions about that content after the end of my portion, as I'm actually on our inpatient consult team right now, and so may have to leave a few minutes before 1, so just to make sure we get all the questions in, and then we'll pass it off to my dear colleague, Windia. So I'm going to share my slides. Great. Everyone can see that okay? Yep, perfect. Yeah, so thanks, John, for the introduction and for having us today. We are excited to talk from 2 different perspectives. My perspective as a physician and overseeing the sort of implementation and design and development of our substance use programs, which has really been focused on bringing addiction treatment and recovery support back into the general medical setting, where people are showing up often with the acute consequences of untreated substance use disorder, and then turn it over to Windia, who manages our program and has been a part of this amazing growth and expansion. So our objectives today are to start by reviewing just generally our effort to integrate substance use disorder care within general medical settings and why we've done that, why that matters, and what the model has been, and to briefly tell you about the substance use disorder initiative, of which our recovery coaches are one piece of an amazing overall team. We'll talk briefly about the evidence and some of the evaluation we've done around recovery coaches within our program, and then the growth of the recovery coaching program, and turn it over to Windia to talk about that expansion, and then importantly, some of the important factors for recovery coaching success in general medical settings. So obviously everyone here who's committed to this topic and spending their time as a part of these amazing webinar series is aware of the worsening and really deadly overdose epidemic that we're seeing across the country. And in addition to the worst overdose death crisis we've ever seen as a nation, we're also seeing rising and worsening racial and ethnic disparities in overdose death rates. And we see that here in Massachusetts, where I practice, and we see that nationally. We're in just 1 year for the most recent data that we have from the CDC, although we saw overdose death rates increase amongst all individuals, the highest increase was amongst Black individuals and American Indian and Alaska Native people. And so a reminder of the health harms of racism and the intersectionality of discrimination around substance use, and then racism, particularly given the racist legacy of the war on drugs in this country. The CDC has also looked at, in particular, the interplay between racial and ethnic inequities and income inequality, reminding us of sort of the broad social determinants of health barriers when we think about the overdose death crisis. And in their recent data found that overdose death rates are even higher for Black individuals in counties that have higher income inequality. And amongst older individuals who are vulnerable for many other reasons, overdose death rates are also higher from a racial and ethnic disparity perspective, with a 7 times increase amongst Black men who are older compared to older white men. So I think we often hear in the news and read headlines about just the sort of utter despair and disaster context of the overdose crisis. And obviously that is true, and that is a call to action for all the work that we're doing. I think it's also important to always remember the notion of hope that I think most of you probably have if you're here in this space, that addiction is a good prognosis, treatable health condition, that we have a ton of interventions that we know work, and that we actually have decades of science showing us what are effective treatments and recovery supports and changes that we could be making to save lives. And so for us, the work is really around how do we actually implement that? So how do we bridge the gap between everything that's been shown to work and then what actually happens in the real world, which often is huge chasms in access to high quality and effective care. This is a report from Columbia, now probably 2 decades old, which tells you how long it takes to see real change, where they commented on the profound gap between the science of addiction and current practice, and that this is really the result of decades of marginalizing addiction as a social problem rather than treating it as a health condition. And that much of what is called treatment in the addiction world bears little resemblance to how we would treat human beings suffering with another health condition. And I think the great thing that I love about science is that it's true whether you believe in it or not. So I do think that one of our greatest barriers in some of this implementation work is challenging stigma and stereotype and ideology. And yet we have science on our side. We have great research showing us what are effective interventions and that these can be brought to where people are showing up, including and especially within general medical settings. And so as an addiction medicine doctor and also a general internist, I really think of caring for substance use disorder as very similar to what we do in the rest of medicine. So the essential components of care are just like those for other medical conditions. The better someone will do, for that's for cancer or heart disease or for substance use disorder. We want to talk to the human being who's affected about the diagnosis that they have and give them all of the evidence they need to make an informed decision based on their own preferences and experiences and circumstances about evidence-based treatment. We want to, of course, initiate treatment without delay. And then we may want to refer for more specialized care depending on the severity of the symptom or of the illness and our own ability to manage it. So that's exactly what we do for any health condition. And that's what we need to be doing for substance use disorder as well. And so it begs the question of why aren't all providers doing this if this is the same as for the many other things we manage in the medical system? There have been lots of surveys that ask doctors and other healthcare providers why they don't address substance use disorder. And there are many barriers that are cited that are real. Things like I don't have enough time, I've got short visits with patients, I've got lots of things I have to address, I don't have the right resources, patients are complicated, they have psychiatric comorbidity, they have other things going on. And yet those barriers exist for everything we manage in medicine, especially in primary care settings, where what we specialize in is multimorbidity. Our patients are complex, their lives are complex. And you don't hear that brought up as a reason for why we can't address hypertension or diabetes. And so I think really beginning to poke at what are those barriers and why are they barriers for substance use disorder treatment. I think importantly, you need a team. And I'm so excited to talk with our recovery coaches today because they are the gems of our team when I think of the work that we've done at Mass General Hospital and Mass General Brigham. And I do think that we don't talk enough about the joy and satisfaction of this work, of this field. I think people who haven't gotten the privilege of working in this space often think that this is hard, difficult, depressing, tough work where people don't get well again. And that is completely wrong. This is the most rewarding area of medicine I've ever worked in. I think it's the true joy of what I do every day. And so I think sharing that and spreading that is really important. And our coaches are an important part of that. So at the end of the day, what we're really talking about is how do we create patient-centered care for people with substance use disorder? And patient-centered care is defined as relationship-based healthcare, where the person, the human being that we are partnering with is at the center of that equation. And the orientation of care is towards the whole person, recognizing their culture, their community, their family, their values, their preferences, their past experiences, and their unique needs. And then supporting patients and learning how to manage and organize their care at the level that they choose, which really involves undoing some of the power hierarchies and barriers that have long existed in medical care. And I think to begin to really get to patient-centered care, it's important to acknowledge some of the mythology that healthcare providers have been exposed to, and in fact, many of us have been exposed to, that continue to drive negative or punitive or harmful care in healthcare spaces and elsewhere. And I think one of those is this idea that about tough love. You have to remember that many healthcare providers, including physicians, haven't received any training around addiction. So they don't necessarily know anything more about it, unfortunately, than someone in the general public. And they've been exposed to the same stereotypes and false tropes about substance use and addiction as other people have. And I think tough love is one of those really harmful ones that can sometimes show up in healthcare spaces and how people are treated. One of my favorite articles about this is written by journalist Maya Solovitz, who's a person in long-term recovery. And this is probably 10 or 15 years ago now. And she wrote about the fallacy of tough love and how, she couldn't understand that as a person who was using substances because of past trauma and because of feeling terribly about herself, how would being treated awfully by the people that she loved most in the world help her get well? And that in fact, it was fear of punishing treatment that kept her from accessing care much longer after she realized she had a problem. And I think the reality is that we know with substance use disorder and with any health condition that really kindness and compassion are at the core of what we do. And kindness is what ultimately helps people come into care, want to stay in care and get better. This quote is from an email from a patient who sent to one of our inpatient addiction consult team providers many months after being in the hospital for an infection associated with injection drug use. And he said, I'm not sure if you remember me, but you were a light in my darkest times when I was in the hospital. I just wanted to thank you for the times you came in to talk and listen while I was there. It meant more than you could ever know. We also have, outside of quote and anecdote, rigorous data showing us that empathy and connection and human kindness are important factors of healing. And in fact, a meta-analysis of therapy outcomes found that clients reporting that they felt like their therapist was empathetic towards them was one of the best predictors of eventual treatment outcome. So kindness truly is healing, and our coaches are some of the carriers of kindness more than anyone else on our care team. So I think notion of really supporting any positive change. I think one of my favorite statements in life and a good reminder for all of us is not to let perfect be the enemy of the good, and that for all of us, change and forward movement often happens in steps, not in giant leaps. And when we think about substance use and recovery, and harm reduction as a part of that continuum, really thinking about supporting any positive change is crucial. And I always like this quote that, if our goal is to promote health, then we have to understand that sometimes circuitous paths that through which individuals achieve and sustain health. We have to meet each individual with fresh eyes in every encounter, with the belief that each encounter is an opportunity for movement, no matter how small, towards health or wholeness. And I think this notion has been a part of the core philosophy that we've tried to embrace in our substance use disorder initiative, of really seeing every single touch point with the healthcare system as an opportunity for that moment of kindness, for that small movement towards health and wholeness, however the person defines it. So our MJ Substance Use Disorder Initiative launched 9 years ago now. We started the planning process almost exactly 10 years ago and launched our first clinical service with our addiction consult team and our recovery coaches as the first pieces of that in the fall of 2014. And from the beginning, the idea was really about bringing addiction care back into the medical system. It sounds pretty basic, but was somewhat radical, because certainly at that time, for most people, if they're coming into the emergency room or the hospital with a health condition related to the underlying substance use disorder, so coming in after an overdose, or with decompensated liver disease from alcohol use, or with an infection related to injection drug use, they were often treated for that medical complication and then sent back out into the world, maybe with a list of resources they could try to navigate on their own, sometimes with a stern reminder in their discharge paperwork to not use substances anymore, and rarely or never with anything more than that. So there really wasn't addiction treatment that was happening in the healthcare setting. And so our effort was what would it look like if we utilize these touch points, these moments when people are coming in and they're acutely suffering consequences related to their substance use, and we offer people welcoming, person-centered, low barrier care. That may be formal treatment, that may be really engagement and harm reduction work, that may be recovery support, but utilizing those moments when people show up. And so we set out to integrate across those different touch points, including the hospital, our emergency department, primary care, our behavioral health settings, and then expanding to the perinatal space, thinking about OB and pediatrics. And you'll see a lot of people here and a lot of faces, and that is intentional. Everywhere we went, we tried to build teams, recognizing that people are multidimensional and care then needs to be multidimensional. And so our teams consist of people from different disciplines and different lenses of expertise. We always have medicine and psychiatry working together. We have nursing, we have mental health, whether it's social workers or psychologists, and we have recovery coaches as a part of each one of these teams as essential non-clinical care partners. And so in our Bridge Clinic, which is a low barrier outpatient substance use disorder clinical program, and our inpatient consult team, and our primary care embedded model, and our emergency department, and in our perinatal space, recovery coaches are a part of each one of those teams. And we've tried to evaluate this from the beginning, trying to understand, does this work, and how does it work, and how can we continue to do better? And so some of our early studies incorporated looking at recovery coaches as a part of that evaluation. This was one of our studies that we did where we looked at primary care practices that had integrated substance use disorder treatment, including recovery coaches. And we compared them to practices that didn't have any of those resources. So we took the start of a recovery coach in a practice as the beginning of that intervention of sort of integrated substance use disorder treatment. And then we looked for matched controls. So patients who had a similar type of substance use disorder and similar medical complexity who were in a practice that didn't have a recovery coach and didn't have integrated substance use disorder treatment. And we looked at what the impact was of those integrated resources on people's healthcare utilization of the hospital and the emergency department. And we found that for patients with substance use disorder who were receiving care in a practice that had a recovery coach and this integrated care model, they had a reduced number of of emergency department visits in the 9-month period after the launch of the recovery coaching program, and a reduced number of inpatient hospital bed days during that period. So suggesting that if you make care accessible in the place where people are getting the rest of their outpatient care, that they may not need that acute care utilization, which is often not the best place for people to get their substance use care needs met. We found that, change is possible, including healthcare provider attitude change. And if you think back to where I started this around sort of the barriers around ideology and stereotype and misunderstanding about substance use, we really recognize wanting to create some culture change and help providers also see this as a good prognosis, treatable health condition, and feel willing and able to offer treatment when people come into care settings. And so we did a survey of hospital medicine doctors and primary care doctors before and after we rolled out our substance use disorder initiative. And we found that doctors who'd had a patient receive care from the initiative, so from one of these teams that has recovery coaches on it, like the inpatient consult team or Bridge Clinic or the outpatient program, had definitive changes in their attitudes around substance use in the year afterwards, compared to providers that were just around the system but didn't actually have a patient receive care, had no change in their attitudes. And specifically, we found that providers by a great degree were much more likely to find caring for patients with substance use disorder satisfying when they'd seen a patient of theirs cared for by one of these nurse services. And they were more likely to have less stigmatizing notions about medication treatment for opioid use disorder in particular. Another really crucial piece that tells the story of this work is what patients say about their care. And so this was a qualitative study about our Bridge Clinic and patients' perspectives on what it's like to come into a lower barrier, more welcoming care model. And I think the quotes really tell the power of this type of care. Patients talked about how this care model allows you to heal however you have to, and that the clinic doesn't make them feel like other places have, that they don't get bombarded, they just feel relief and help, and there aren't mandatory rules that make people feel sort of confined or less than. They noted that being able to get medication without strings attached to it was actually important, that there are voluntary offerings that people absolutely take part in, but they didn't feel forced into something. And people talked about that in the past when they've been told that if you have to do all these things, that it actually can have the opposite effect. It can push people out of care. And importantly, feeling like they were treated like a person, that was crucial. Patients felt like staff treated them like human beings, and that staff really wanted to help make their life better. They felt welcome, and they felt like they were happy to be seen when they showed up. And so that made them want to continue to come. So what about the recovery coach specifically? Well, early on, we did a qualitative study, both of patients who'd worked with a coach and also of coaches about their experience, to really understand what is this role in general medical settings. And there were 4 main activities that came out of those interviews, or 4 main themes that coaches helped specifically with. So one was system navigation, so helping patients access treatment, assisting with navigating social service difficulties, and then accompanying the patient to challenging or needed appointments, whether it was being with them when they had a court appointment, or accompanying them to a medical appointment, helping them get to that next step in their care. The next activity was around behavioral modification, and patients identified finding it really helpful to have these discussions with their coach around changing behaviors. And it wasn't just around substance use. Sometimes it was multiple wellness domains around diet or exercise or other health-related and wellness-related goals. Patients found it important, and coaches found it important, that harm reduction was incorporated as a part of this role, that coaches felt comfortable talking about harm reduction as a part of the continuum of treatment and recovery. And sometimes that meant helping people get clothing and food if they were hungry or if they were unhoused. And sometimes it meant more concrete harm reduction services. And then critically, relationship building was at the core. So patients really identified the value tremendously of engaging with their coaches without a specific agenda. So it wasn't like coming to a medical appointment or therapy appointment. It was really about building a relationship. And sometimes that happened on the street, sometimes that happened over food or coffee, but it was at the core of everything that people valued about this role. When asked, patients identified sort of 4 particular strengths of the recovery coach role in general medical settings. One is accessibility, that they felt like they could reach out to their coach, that wasn't something that experienced with healthcare teams, where there's often multiple hurdles to connect with your doctor, your nurse, or your therapist, that they could just reach out to their coach if they're having a hard day and connect with them in a really easy way. The shared life experience was incredibly important. And in our model, and this varies for some places, but all of our recovery coaches have their own lived experience experience of recovery and identifies people in long-term recovery. And that was really helpful for patients to feel like the person understood in some way about their experience. Patients found that their coaches help motivate positive behavior change, and that sometimes could be not leaving against medical advice from the hospital when they were there for an acute medical issue. And sometimes that was around recovery changes and substance use specifically. And then the link to social services that coaches often knew, even though there are other people on the care team like case managers or social workers or community health workers who may be doing some of the direct navigation, that coaches often have a wealth of knowledge about local resources. And recoveries may feel more comfortable asking their coach than asking someone formally on their clinical care team. There were some challenges. So for some patients, especially early on, it was challenging when they're first building a relationship to ask for help, even though they trusted their coach. I think it has become very apparent as we've rolled out our program. I'm sure Wendy will talk more about this, about the importance of really being clear about what the role of a recovery coach is, both clear for coaches, clear for patients, but also clear for the care team who may be new to this model. And one particular challenging situation is for patients who have severe co-occurring psychiatric comorbidity like active suicidality, and making sure that we're clear about the coach role and what the clinical supports are and clinical interventions are, that shouldn't fall on a coach's shoulders. And then I think this idea of the tension between the coach and the care team, and this gets to some of the work of preparing care teams and care systems to be ready to have recovery coaches as a part of a model, to really understand what is this role and how it is distinct and not a clinical role, and the incredible value of it. And so you can see here some of the quotes of that like some of the medical team members were not really sure what to do with a recovery coach early on. And so that was an important piece of getting the program up and established. In addition to the qualitative work, we've also looked at the impact specifically of recovery coaches on healthcare utilization, with the idea that as people get well and stabilize from their substance use disorder, we would expect them to engage more in the outpatient setting and to have fewer hospitalizations and emergency department visits. And in fact, that was what we saw. So you can see here week 0, which is the darker bar in both of these, is the initial engagement with a recovery coach. And that after engagement with a recovery coach, we saw on average that patients' inpatient utilization went down significantly, and their outpatient utilization increased significantly, particularly outpatient utilization for behavioral health visits and for medication visits. And so really emphasizing the important sort of human glue that coaches can be as a part of that care team, and helping people be able to engage with an addiction treatment plan and their behavioral health care and other aspects of their health care. Building off of this model of success that we experienced at Mass General Hospital, we've also worked to expand this across our broader integrated medical system called Mass General Brigham, which includes Mass General Hospital, as well as Brigham and Women's Hospital, and a number of other community hospitals and outpatient care practices. And so between 2017 to 2021, we expanded to 23 full-time recovery coach roles across the system. And in that time period, they saw nearly 7,000 referrals for 5,662 participants who are enrolled. So really high overall enrollment rate. So of people who are referred to coaches, 83% of them actually enrolled with a recovery coach. Looking at the most common referral sources, social work, the emergency department, community outreach, and primary care providers most commonly referred patients to recovery coaches across the system. And we found that the type of substance use was not different amongst people who were referred and not enrolled compared to those who are successfully enrolled. Looking at the most common types of substance use that we see amongst people who are referred to a recovery coach across the system, people probably won't be surprised here that alcohol is number 1 and opioids are number 2. So you can see in the blue that alcohol is by far the most common, ranging from 43 to 52% of referrals. Heroin and fentanyl is the next most common for about 20 to 25%. Cocaine after that, then prescription opioids, cannabis, other types of substance use, benzo or sedatives, and then tobacco and synthetics are the lowest. We've also looked at the race and ethnicity of participants who are engaged with a coach. And so these are 5 different sites where we have recovery coaches across the system. And you can see there's a range depending on the site, with one of our sites having much more diverse representation, with 24% of their recoveries identifying as Black, and across the system, 13% identifying as Hispanic or Latinx. I think as you'll hear more, recognizing that equity needs to be at the core of everything we're doing when we think about our substance use disorder work, and in particular, given the worsening racial and ethnic disparities around overdose mortality across the country, we've begun looking at how important representation is, from diverse representation within our recovery coach workforce in particular. We looked at whether racial and ethnic concordance between coach and participant impacted people's outcomes, and we found that there was an impact. So amongst Black recoveries had a higher rate of enrollment when they had a Black recovery coach. And so the odds of enrollment for a patient when there was patient coach racial concordance was almost 5 times higher. So really emphasizing the critical importance for outcomes in thinking about diversity and representation within our workforce. We also found amongst participants who identified as Hispanic or Latina, their active participant months were longer by 1 month on average if they had a coach who also identified as being Hispanic or Latina. So again, the importance of that sort of diversity across our workforce. With that, I want to end with a quote. I think the opposite of tough love, and thinking about how important hope is, and how that hope and kindness and engagement is just at the core of everything we do. And I think our coaches serve as absolute beacons of hope and role models for the rest of our care team, and have been really, as I said, the human glue of this work. And I've learned so much working alongside them and everything that we've done. And so with that, I'm going to take a moment for questions if people have any. I'll look in the chat, and then I'm going to be delighted to turn things over to my dear colleague, Wendia. So I see one question in the chat from George, and I'm going to stop sharing so people can see faces. So Dr. Wakeman, how often and who from the medical staff are involved in processing patient challenges with recovery coaches pre and post discharge? So great question. So Wendia may get into this more around supervision, but I think we've thought a lot about the needs for supervision, especially in these relatively intense settings of like the emergency department and the hospital, and the work that our coaches are doing and exposed to. And so all of our coaches have a recovery coach supervisor. So at MGH, that's Wendia, and she'll talk about her role. So someone who's been certified as a recovery coach supervisor. They also have a clinical supervisor. So someone in their specific care setting that they can talk to about clinical issues or clinical cases. So that often is a social worker or a therapist, like a behavioral health person, but sometimes it's a physician, depending on the care team model. So, our coaches, again, are in lots of different spaces. So some are on consult teams, some are in primary care, some are in bridge clinic, but in each one of those locations, the coach has a clinical supervisor they can go to. We also have a separate psychologist who's actually not related to their sort of leadership structure at all. So it's not their manager, it's not their clinical supervisor, that they meet with monthly to just talk about their own wellness in a space that's completely removed from their employment. And I think that has felt really important for coaches to feel like they can talk about their own recovery and their own wellness with someone who is not their boss, doesn't know anything about their job, but is just there to focus on coach well-being. And so that's an additional support that they have. Okay, do the coaches use any sort of protocol or curriculum in their work with patients? So I'll leave some of that to Wendia. All of our recovery coaches go through the State Recovery Coach Academy training, and they also do a fair amount of continuing education. And Wendia has also led a number of ongoing educational and training efforts around a range of topics. And so I'll defer that one to her. How are the recovery coach positions funded? So this is a great challenge, an area for much needed policy change. So all of our coaches are funded by the hospital. Some of them are grant funded, but the majority are funded by our healthcare system, which I think is a testament to leadership's recognition of the importance of this role, that this is a really critical piece of the work we do, and also why some of our evaluation work is focused on value, to show that an inpatient hospitalization is a very expensive thing, and if coaches are a part of helping people stay well and stay out of the hospital, that's a valuable investment. So it's not only sort of the right thing to do for patients, but also a smart thing to do for healthcare systems. In Massachusetts, our state Medicaid program does reimburse for recovery coaches, but many of our commercial payers don't. And so billing has been limited around recovery coaches. But I know at least here in the state legislature, there's a couple bills around recovery coach billing that are being put forth. And so hopefully that continues to expand. I think the training we talked, the training for medical personnel. Yes, so that's a great point. So how do we get teams ready for recovery coaches? So we actually developed a recovery coach toolkit for people on the healthcare team that goes through in great detail, what is the role, what sort of in scope and out of scope, what kind of training do people receive, how to work with a coach, just to really give people a primer on what is a recovery coach. And so that's something that's available to all members of the healthcare team and something that clinical supervisors in particular look through. And then obviously our recovery coaching supervisors are all certified and understand the role quite well. And then I think the last question is around tough love as it pertains to recovery coaches. Well, I think tough love in general, I'm sure people have different definitions, but this idea that if you make someone's life harder, that's going to make them make changes to their substance use has often been one that has permeated sort of notions of substance use. And I think if we understand addiction, the definition of addiction to be compulsively using alcohol or drugs despite bad things happening to you, by definition, people are not making changes to their substance use despite negative consequences. And if you think about how our society has often responded to drug use, it's been around punishing people. So, what do? We send people to prison, we take their children away, we take their jobs away, we kick them out of the hospital, we take housing away. And we do a lot of things to make people's lives worse instead of recognizing how do we actually make people's lives better? How do we make recovery the easy choice? Why would you want to make changes to your alcohol or drug use if you're unhoused and on the street and dealing with daily trauma and stress? And so how do we flip that notion to really think about how do we start from a place of compassion and compassionate curiosity and really partnership with people around figuring out what their goals are and how making changes to their substance use they see will cause their life to get better in some way. And that becomes part of the work. And so I think undoing some of those older approaches has been a really important piece of this. And I think our recovery coaches really embody that notion of sort of partnership and orientation towards recovery, defined wellness and recovery, and supporting people on multiple pathways. It's been really beautiful to watch. So with
Sarah,
that, sorry, John.
No, Sarah, thank you. No, I know you have to go. So I just wanted to say a big thank you for doing this, for bringing your passion expertise to this forum today, but also what you've done here at Mass General has been massive. Your energy and compassion and education, the education you've brought to the whole hospital-wide has been phenomenal. I mean, you've affected so many people's lives in a positive way. Thank you for that work, as well as for what you've done today. Thank you for that, Sarah.
John's been an amazing partner from the very beginning. So you can imagine that he's old enough to have been here 10 years ago. He was, and he helped us from the beginning. So with that, I'll turn it over to Wendia, and thank you so much for having me.
Thanks, Sarah.
Thank you, Sarah. Okay, I'm going to share my slides. Again, my name is Wendia Rodriguez, and I'm the program manager. Just pull up the slides. Okay. Okay. I can't see my full screen, so I apologize. We're just going to kind of do it this way.
Yeah, we see your slides, Wendia. It looks great. I think it's not in present, it's not like in a screen share mode, but otherwise it looks good.
Okay. All right. So welcome everybody again. Sarah, thank you so much for all that information. I've known Sarah for a really long time, and it was a pleasure to join Mass General in 2020 amid the pandemic. And taking on this role was a little scary for me. And transitioning from being a coach to now managing or supervising coaches was definitely something that I didn't know that I could do, but I've had a lot of support from Sarah and from my other managers as well. So the objective of my presentation is to review the goals, skills, and tools of a recovery coach in a medical setting, describe how to make a referral and ways to make the referral meaningful, detail the differences of a recovery coach, addiction counselor, and a sponsor, and summarize the management and supervision of recovery coaches. So the goals of a recovery coach is to serve as a personal guide, a mentor, I like to say a cheerleader, advocate, truth teller sometimes, To answer that other person's questions, we don't necessarily give tough love, but we offer truth telling, and we always ask for permission and say, can I share some feedback with you? That was always my go-to before sharing something. And only if a person asks. Like Sarah said, we really try to remain person-centered. We try to maintain fidelity to the recovery coach model, and we use various tools to engage participants. So one of the things that I always tell people is when someone comes in, ask them what they want to do. What is it that you want to do? What goals do you have? Because right from the start, you're engaging them and making this person-centered. And the skills and requirements of a recovery coach. At Hire, we say that they demonstrate the skills needed to maintain a minimum of 2 years in recovery. Now, what that means for some people might be different. So we don't, when we're in the process of interviewing, we can't ask people if they're in recovery. So that's a no-no from HR. But if somebody discloses, we also don't ask them how long or, if they're on medication. We don't ask them things like that because at the end of the day, people are in recovery when they say they are. And if somebody, let's say, had 5 years of recovery and maybe they had a setback and now they're back for a year, they still demonstrated the skills needed to maintain 2 years. They just had a setback. Recovery coaches here at MGH are mobile in their role and they meet patients in the community. So all of the coaches here are equipped with cell phones. They also have their business cards and laptops, so they can really work anywhere in the community. Sarah touched on, some of the challenges and barriers that people face. Recovery coaches are able to go to court with people. They're able to meet people in cafes and just really engage with people in their own community versus them always having to come to the hospital. And again, maintaining fidelity to the recovery coach model while upholding the policies and procedures of MGH. So, Sarah touched on how challenging that may have been in the beginning. Integrating a non-clinical role in a clinical setting, both parties had to really get to know each other. So the recovery coaches won't diagnose, but they learn a lot about how the medical team operates and those sorts of things. And in exchange, the medical team also understands how a recovery coach is ran. And here in Massachusetts, we require that people complete the 5-day Recovery Coach Academy, which was written from CCAR, and it has been revised, renewed, updated almost every year. And it's 5 days normally in a row. Some places now, certain colleges are doing the academy on Saturdays to accommodate some people because not everybody can take 5 days off of work. So they're really, different people are finding ways to accommodate people. And we ask that people become certified. So here in Massachusetts, they go through a process of becoming certified. So Sarah touched on some of the trainings. There's Addictions 101, motivational interviewing, DEI, mental wellness, self-care. These are all trainings that coaches need in order to become certified. So there is, continuing education. And then on top of that, we ask that you have 500 working hours and 35 hours of supervision under somebody who has gone through the training like myself. So it's a pretty rigorous process. And now there's also a test. It wasn't a test when I had to do it, thank God. But it's a pretty rigorous process now. And, but coaches go through it, the hospitals supports them in their trainings, and they continue going to some of these trainings to remain certified. So these are some of the tools. Sarah touched on a few of them. We really use motivational interviewing in our role, harm reduction techniques, and not just, giving clean needles. Recovery coaches have talked to people about how to reduce their alcohol use or substance use, finding ways and techniques to use a little bit safer. It can't be 100%, but harm reduction is really at the core of all of our coaches. I've already mentioned mobility and flexibility to meet in the community. DEI and racial justice is very big. We also have coaches who have lived experience as veterans, and that has also made a difference to touch other veterans. We have a coach who is a mom, who's a peer mom, and those are some of the ways that we also integrate social justice and other types of congruence in our team. Our own story of recovery is really important, but I like to help coaches kind of tailor that story to make sure that they're not telling their whole story. They know when to tell it. They know how much to tell. When I was coaching and I would tell somebody that I was in recovery, that was all they needed to kind of just, those walls just come down. So once they knew that I was a peer like them, they felt more comfortable. And Sarah mentioned the social services, and somebody asked in the chat about do we use protocols? We don't use any specific protocols, but there is something called a wellness plan that comes from the academy, and it has about 7 or 8 domains in that. And so again, we would ask the person if this is something that they would want to work with. They would fill it out and they would identify which goals are the most important. So if they say, housing is the most important, that's what we would work on. If they say they want to reconnect with their church, that's what we would work on. It's totally up to them how they want to do the wellness planning. And recovery coaches endorse multiple pathways. This is one of my favorite pieces about recovery coaches and the recovery coaches here at MGH. We all have different pathways of recovery. And, that includes medication, outpatient or inpatient treatment, body work such as yoga. We have a, we have a gym here in Boston that's free for people who are in recovery. All you need is 48 hours and they don't test you. Total honor system, but it's called Phoenix Multisport. And you can actually start a chapter in your area as well. So it's called Phoenix Multisport, and it's 48 hours. You can start a walking group. You can do any of those things through Phoenix Multisport, and they will help you with that. And of course, we have here in Massachusetts 40 now recovery support centers. That's where I got my start, and they are really amazing places for people to go and be safe and volunteer and, really kind of get their footing in the recovery community. So this is how and when to make a referral. You can do warm handoffs. That's one of the best ways that I think makes a good referral. You can do that in person, conference call, telehealth. The person can be invited to meet with a coach. Of course, the coach needs to be supported by a care team, supported by the provider. And sometimes when referring to a coach, instead of saying a recovery coach, we found that saying peer support draws people in faster because not everybody is ready to really identify as a person with substance use disorder, and they may run away from the word recovery. So when we say peer support, I would always tell, clinicians, please feel free to let them know that I'm in recovery, and that seemed to work really well. And all they need is like a diagnosis of SUD, maybe problematic substance use. Maybe they present to an appointment under the influence, or if they request help. All they need to do is be willing to speak to a coach. And here we have a chart. This is from William White. The differences between a recovery coach, a sponsor, and addiction counselor. I've been asked many times, what is the difference? And one of the big differences is a sponsor is usually from a 12-step fellowship. And recovery coaches don't endorse any particular fellowship, even if that is our pathway. We don't endorse that, so we don't become people's sponsors. We don't go through steps with them. That's one of the biggest differences there. And then with an addiction counselor, we're able to disclose that we're in recovery. So if an addiction counselor was in recovery, they can't disclose, but we disclose. And there's some overlaps, as you can see, but there are really clear differences in this. And we've had some recovery coaches who are also addiction counselors, and they've been able to take off their hat as an addiction counselor or take off or remain in the recovery coach model versus trying to diagnose people. So it can work for people, but it's really sometimes challenging for people to switch hats. And again, patients just need to be ready. They don't have to be committed to a certain pathway. They don't have to desire abstinence. That is not our goal as a recovery coach. Our goal is not to help people become abstinent or, you know, get them on medication to, you know, until they're ready. That's not our goal. Our goal is what the recovery says it is. And the management and supervision of recovery coaches. So again, here in Massachusetts, we have we go through a process of being certified as supervisors, and we're the only ones who can sign off on somebody having that supervision. And in 2018, the recovery coaches here document in EPIC, which is our electronic medical system. And they have their own kind of build because recovery coaching, again, is non-clinical. So their notes and their documentation looks very different from other people. And they don't discharge patients. They have a panel, but we don't discharge any patients. So we have some coaches who've been working with people for years. And then supervision, what I do is I have a mandatory 2 meetings a month with the whole team, with all of the coaches we have. They meet with some coaches, we meet with me regularly, like once a month or twice a month. And they attend group, like I said, group supervision, and they ensure that coaches have really good support systems. That's one of the biggest pieces when you're hiring coaches. You have to have, they have to have really good support systems. And in conclusion, recovery coaches are person-centered, and our motto again is you're in recovery when you say you are. Recovery coaches are an integral part of any care team. Please ensure that they're welcomed, supported, and utilized properly. And recovery coaches are amazing, strong people, but they're also can be vulnerable. So self-care, strong supervision, and continuing educations are keys to successful integration. So I'm going to stop sharing. I know we started a little bit late, and it looks like there's a lot of questions.
Yeah, Windy, thanks so much. It's just absolutely fantastic. Thanks for that great overview. You know, we didn't give you a lot of time. We didn't have a lot of time, unfortunately, today, but thank you for that. But let's end with a few questions. Maya, do you want to pick out some of the questions for Windy?
Absolutely.
I know they're kind of intermixed there, you know, kind of here and there, if you can find them.
And I apologize, I couldn't put it in presenter mode. I couldn't see, once I started sharing, I couldn't see my whole screen.
Okay, so one question we had, I believe this was from Dr. Weekman's portion, but this is the start of your part, was Medicaid mentioned as reimbursing for recovery coaching?
Yes, so here in Massachusetts, like coaches don't have to do the billing portion of it. Once they document, and that's taken off of our plate. So Medicaid will reimburse. I don't know the ins and outs of the financial piece and how that works, but that's how it works here in Massachusetts. And I know other states are different, but we had to do work around that to get to that point. We had to do a lot of advocacy work on that before they would reimburse.
And then we have another question from Thomas, and Thomas asked, why recovery coach as opposed to peer recovery support?
So again, some people are not ready to identify that they have a substance use disorder. If people know about the stages of change, they may still be in pre-contemplation. And you know, when you, as a clinician, if you tell them that this person is a peer versus this person is a coach or a recovery coach, they tend to be a little bit more open. And so that's why we, use that language sometimes, because we want to remove those hierarchical pieces of it too. So once they hear peer, they know that it's somebody that's on their level.
Awesome. And those are all the questions in the chat so far. So if people have other questions, feel free to drop them in the chat or unmute yourself.
Yeah, unfortunately, we're out of time, sadly, for today. But I want to say a big thank you to Windia and Sarah. I know Sarah had to take off, but Windia, thanks so much. It's always great to see and hear you. I know you don't remember this because I've talked to you about this before, but I think it was 12 years ago. You were in our first video. I don't know if you remember this. I asked you this a while back, and I don't think you remembered. I think it was when you were at Step Rocks. You were in our video for the Recovery Research Institute, the very first video, talking about, the whole thing about what we were going to do with the Recovery Research Institute when we founded it 10 or more years ago. And do you remember that?
I do. I do. I remember we came to MGH to view it.
Yeah. And so anyway, you're in the archives forever because of that. So I want to thank you. I want to thank you again for doing that, because your presence and what you said about recovery was just it was just fantastic. It was just a lovely piece in the video. So thanks again for that. And thank you for today and for all that you're doing across the hospital and just helping so many people, changing so many lives with what you're doing. Thank you for that. And thanks everybody. I'm sorry we ran out of time. Always wish we had more time for these things, but please join us again next time, which will be September the 13th, I think, Maya, with Ashley Shado. We'll be talking about young people in recovery and I think the interface with criminal justice, I believe, in the justice system. And then in February, we have Dr. Roger Weiss talking about medications and mutual aid, I think, in February. So come back. We'll see you. Have a great summer, everybody. And we'll see you next time. Thanks for joining us.
Thanks, everyone.